Welcome to AETCM, the emergency medicine channel. Shall I start?
Yes.
A 60-year-old female patient, non-case of diabetes and hypertension, presented to the emergency department with complaints of fever, right lower limb pain and swelling, redness for the past 2-3 days. On initial 10-second assessment, patient is conscious, oriented, obeying commands, airways patent, no secretions, breathing, air entry bilaterally equal, saturation is 97% in room air and respiratory rate is 18 per minute. BP is 140-80 mm of Hg, pulse rate is 90 per minute and all peripheral pulses equally palpable. Disability, GCS is 15/15 with pupil bilaterally equal and reactive. Exposure wise, temperature is 101, GRBS is 286 and pain score is 5/10. At that time we secure one IV cannula and injection PCM 1 gram IV stat was given. And also we took the blood investigations. We show CBC CRP, total count is 13,000 with platelet 2,22,000. HB is 9.2 with CRP 72. VBG wise, pH is 7.405 with bicarbonate 23 and PCO2 is 43. Lactate is 1.9. And proceeding with the ample history, the patient is 60-year-old female patient, non-case of diabetes hypertension, presented to the emergency department with complaints of fever and right lower limb pain, swelling, redness for the past 2-3 days, developed following a scratching over the limb. She noticed minor abrasion initially, that is followed by swelling, redness and pain over the same area associated with intermittent fever episodes. She also developed generalized tiredness and decreased food intake. There is no history of immobilization, recent surgery or shortness of breath or palpitation. No history of loss of sensation or blackish discoloration, skin peeling or blebs at the same side. There is no history of unknown bite or joint pain. There is no history of exposure
Unknown
to...
bite means there is
no history of noticed any. There is no history of exposure to any contaminated water. No history of altered behavior or decreased
water.
In contaminated water, chances of infection through the contaminated.
Infection by?
In seawater and all, Vibrio vulnificus and Vibrio parahemolyticus.
Vibrio vulnificus is very important organism. Okay.
And no history of altered behavior, no history of decreased urine output, no history of similar episodes in the past. And patient is diabetic.
Why similar episodes in the past?
So there is any recurrent episodes of similar complaints. We have to, in management also, we have to hike up the antibiotics and all. And there is chance for any immunocompromise.
So recurrent infection in an area, that is a breach in your skin. Okay, that is your immune protective mechanism. Skin is a protective mechanism. So once you get an infection in that area, there is high chance of recurrent infection. Like you told, the antibiotic has to be high according to the previous hospital administration. Yeah. Then third one is prophylaxis. He may require prophylaxis if he gets repeated infections.
We also can check for any immunocompromised states, any malignancy and all for the patient. And patient is diabetic on OHA, metformin plus glimepiride combination.
Diabetes is immunocompromised state or not?
Chances for recurrent infections.
Diabetes is immunocompromised state. Uncontrolled diabetes is immunocompromised state.
And hypertension.
What will happen to the skin in diabetes?
It will...
especially lower limb.
Will become dry and...
dry. The patient will develop autonomic neuropathy. Sweating will be reduced. Loss of air. Skin will become dry. All are prone for an infection.
And on examination, there is no pallor, icterus, cyanosis, clubbing, unilateral limb swelling present with redness, and that swelling is present over the dorsomedial aspect of the right leg, extending just above the ankle to the middle of the calf region. Local warmth was present and it is tender to touch and peripheral pulses are palpable. No crepitus, no lymph node palpable. Capillary refill time is normal, less than 3 seconds, and there is no restriction of movements at joint. And weight bearing is also able to do. And initially, according to the initial investigations and according to the examination and initial investigations, we reached a diagnosis of an infection to the lower limb, that is in the level of skin and subcutaneous tissue. most probably cellulitis picture. And we also done one USG Doppler to rule out DVT and also any localized abscess collection. In DVT, there is no presence of, in USG Doppler, there is no presence of DVT. And in the initial management wise, we advise the patient.
You have a patient who is already having a leg swelling. On top of that, he had developed an infection.
So we are initially advised limb elevation to the patient and adequate dressing for the same.
What dressing?
We can give normal saline dressing or
saline dressing or
we can give magnesium sulfate dressing to reduce the swelling.
Edema.
And we also advised for application of oils and
water conditions, the leg edema will subside when you elevate the limb.
In case of for the proper lymphatic drainage and also in case of chronic insufficiency of venous and lymphatic
edema can be reduced when you elevate the limb. Whereas hypothyroid edema,
it will be non-pitting and
it is non-pitting and it is an accumulation of the fluid in the subcutaneous vein that will not be removed.
And we also suggested antibiotics. Since the patient is an immunodiabetic and the CRP and all elevated, we suggested IV antibiotics and we started on injection flucloxacillin 1 gram IV.
Flucloxacillin. What is the action? What is the spectrum of this antibiotic? Spectrum.
Flucloxacillin.
Flucloxacillin. Basic drug is cloxacillin. Okay, it's a derivative of cloxacillin, ampicillin, cloxacillin. They cover which type of organs? Gram positive?
Gram positive.
Gram positive. In gram positive, what type of organs it will cover predominantly?
Methicillin sensitive.
Methicillin, MSSM. Methicillin sensitive Staphylococcus aureus. That's why we are giving MSSM. Okay, not for MRSA.
And we started on antibiotic and also we...
What is the dose of flucloxacillin?
1 gram IV, 6 hours.
6 hours.
And we also suggested the patient's HbA1c is around 9.2. So we suggested adequate glycemic control and
with what glycemic control?
We can since the patient BP and everything is normal, not in dehydrative state, we can give subcutaneous injections, insulin.
Okay. Can we treat with OHS?
Already patient is on OHA, so since the patient is get admitted, we can give insulin.
Better to treat with insulin. Whenever you are treating an infection, it is always better to control the sugar with insulin.
And we also advised a TT prophylaxis for the patient, and we marked the point of swelling so that we can understood that whether the infection is getting subsided or there is any progression of the disease. And
when will you add clindamycin?
Clindamycin has an antitoxin action.
So when will you add?
So if the patient is immunocompromised or any necrotizing fasciitis picture,
or if the patient is very sick. Showing signs of systemic toxicity, hypotension, fever, high degree fever, tachycardia, then you may have to add clindamycin to prevent the toxic shock syndrome.
And if there is any history of recurrent cellulitis, we can add prophylaxis. We can add Pendit 400 mg BD, oral penicillins. And the risk factors for cellulitis is lymphedema, skin breakdown, site of entry and venous insufficiency, leg edema, obesity, in case of neutropenia and immunocompromised state, and also in chronic liver disease, chronic renal failure. And in fresh water, there is chance for Aeromonas hydrophila, and in salt water and fish fin or bone injuries, Vibrio fulnificus and Parahemolyticus. And
when will you add gram-negative coverage to the regime?
If the patient is
this is only gram-positive you are covering.
There is a recurrent history of cellulitis and recent hospital admissions.
If it is a chronic infection, better to add a gram-negative coverage which acts on the skin. Or if the patient is having recurrent hospital admission, then also you have to add.
And there is also a laboratory risk factor for necrotizing fasciitis score is there. If it is more than 6, there is chance for necrotizing fasciitis. That includes CRP, which is more than or equal to 15 milligram per DL. We can give the score of 4. And WBC, if it is more than 15,000, score is 1. And if it is more than 25,000, score is 2. And HB is less than 13.5, the score is 1. And if it is less than 11, it is 2. and it includes sodium, which is less than 135, score is 2, and creatinine is less than 1.60. If it is more than 1.6, it is 2, and it also includes glucose. Totally CRP, WBC, HB, sodium, creat, and glucose included in the laboratory risk factors for necrotizing fasciitis. And also the risk factors includes the advanced stage diabetes, alcoholism, previous history of PVOD, heart disease, renal failure, and any decubitus
compartment
ulcer.
syndrome?
Compartment syndrome, if the swelling increased and it extends up to the level of the fascia and muscle, so that the total pressure in that compartment will increase.
What are the side effects of compartment syndrome?
There will be necrosis of the
Because that happens anyway. This cellulitis, if you don't treat, necrosis happens.
ischemia of
It will compress the blood vessels and nerves in the compartment, and it will kill the whole limb. Okay. What is the clinical finding of compartment syndrome?
Pain over passive.
Pain is the major finding. If you get a patient with cellulitis with unusual or unexplained pain, then you have to suspect compartment syndrome. What is the treatment for that?
Fasciitis.
Okay.
So we can involve the surgical department also. If there is any features of necrotizing fasciitis or compartment syndrome, we can involve them also to do the procedure.
Okay. Anything else? Okay. Thank you.
Thank you, sir.